So hello, everyone. I want to introduce a special guest who I've known pretty much my whole entire life, Dr. Ari Ciment, a distinguished specialist in pulmonary and critical care medicine at Mount Sinai Medical Center in Miami Beach, Florida, where he serves as an attending physician and the fellowship director for pulmonary and critical care. With a robust academic background, Dr. Ciment earned his bachelor's degree from Yeshiva University, graduating magna cum laude, and his medical degree from Rush University Medical College. Dr. Ciment completed his internal medicine residency at Robert Woods Johnson University Hospital, followed by a prestigious fellowship in pulmonary and critical care Mount Sinai Hospital in New York. He holds board certification in internal medicine, pulmonary medicine, and critical care medicine. In addition to his clinical expertise, Dr. Ciment has held significant leadership roles, including president of the medical staff and the chair of the Quality Improvement Committee at Mount Sinai Medical Center. His proactive role during the COVID-19 pandemic as a principal investigator for the convalescent plasma program highlights his commitment to innovative patient and public health. Dr. Ciment is an accomplished author and educator, peer-reviewed many publications, and his notable works include Breathless Tales, which I'm going to be referring to a lot, and the coronavirus pandemic, being recognized as one of the top 10 most influential books by the Jerusalem Post in 2020. Dr. Ari Ciment's extensive experience, leadership, and dedication to both medicine and community makes him a highly respected figure in his field and an exceptional guest for today's podcast. So I'm going to get into today with Dr. Ari Ciment, or I'm going to call Ari because he's a very close friend of mine, in his mind as a pulmonologist, but also really to understand what it was like during the COVID-19 pandemic. But I want to give a little bit of background about Ari and I. So Ari and I were both born at Mount Sinai Medical Center, Miami Beach. We both work at the hospital that we were born at, which is very rare. There's only a few of us. And I've known you for a long, long time. I grew up in your house. We spent holidays together in your house. We played a lot of sports together, specifically on the weekends. So Ari, just let's go back and what's it like to hang out and 50 years later, sitting together talking about our experience as doctors?
Wow. Well, thank you for that introduction. Yeah, Stephen has been one of my closest friends growing up. I just remember, so I'm around 50 now, so it's got to be over 40 years ago, even more than that. Just every Sunday, my routine was call up Stephen Resnick. Let's see what he's up to. I'm going to arrange a football game at the golf course or a football game in front of your house. And we played either a 2-on-2 or a 10-on-10. I always organized the game, but it's always Stephen. Whether or not Stephen could make it, that was whether or not the game was good.
I remember growing up and playing basketball at your house, and every time I would drive by your house, you'd be playing basketball hours after hours after hours, to the point where if we ever played at your house, you knew every single little crack and corner that you hit a shot. I think it was a little unfair, but it's okay.
Yeah, exactly.
One of the other things is I remember, Ari, that we could talk about my height. So I was the smallest kid in the class, right? I was the skinniest, smallest kid in the class. I used to tell people that one day I was going to be tall, and I used to get a laugh. And I remember in 7th grade, 8th grade, 9th grade, I still was probably the shortest kid in the class. I transferred into another school. And then during high school and college, I had this crazy growth spurt. I'm 6'2" now. My license is 5'7". Wow. What did you feel when I used to tell people that I was actually going to be tall?
Yeah, I couldn't believe it. This guy was a tiny guy, and then all of a sudden he started working out crazy muscles. That was great commitment.
So Ari, talk to me. You're one of four, right? And you became the doctor of the family, and your dad is a pulmonologist, and you became a pulmonologist. What was the time where you said, you know what, I'm going to be a pulmonologist, and what was the turning point that you actually want to be a doctor?
That's a great question. Actually, when I wanted to be a doctor because I always, I used to watch my father growing up, but also, besides my father, also the Galbit family. We were very close with both my father's partner, Robert Galbit, and his brother, David Galbit, is a big-time heart surgeon, as you know. And as a young kid, I used to watch him do heart surgery. And he used to say, oh, here. And at that time, it wasn't like nowadays, a lot of the bureaucracy. You actually, scrubbed in and you're a 10-year-old kid and you're holding a scalpel, and he's like, oh, this is the 18th step of the cardiac surgery. So I think I actually credit David Galbit for being an inspiration and going to medicine just as much as my father initially. But I was not interested in pulmonary or critical care in medical school. I was actually more interested in neurology, neuroanatomy, ER. And then at the end, the last year, my father said, it would really be nice. He always was open-minded. And he said, you really have to think about yourself. And then finally, when push came to shove, my father said, wouldn't it be nice if you joined me in practice? And that was the best 10 years of my life, was able to go into practice, eventually, go into pulmonary critical care to go with my father and Robert Galbit and be partners. That was the best 10 years.
It's pretty amazing having a father and son relationship and being doctors, and your dad still practices, which is amazing.
Yeah, he does, but now he does internal medicine mostly, but yeah.
So my wife has a little nickname for you, so I'm going to let you know what it is. So the nickname is actually Mensch Cement.
Wow, that's nice.
So a mensch is someone who has honor and someone who's respected and someone who does good all the time. And when I mention your name to anyone in the community, and specifically residents, doctors, patients, automatically a smile, automatically is most of the time very good things, because you are known to be somebody that's in it for the right reasons. Do you feel that you give a care? Because I'm going to get into why you're so different than any other doctor. What is it that makes you different than most pulmonologists or physicians?
That's really nice. I don't really consider myself to be that special, but I am in it. I just feel like I do have sympathy and empathy. I try to think about what it's like to be in that person's position. So oftentimes, we don't see ourselves in that position, and then we fail to really be invested. So I think I just try to have rahmanus, or compassion. So I think, going back where I know we're going to talk about COVID, but those cases where people were completely desperate, I try to put myself in that position. I'm like, oh my God, what would it be like? It's not about the money. Thank God I was offered many opportunities over these many years to stop working, and great opportunities. And I sort of regret to some degree those things. But at the same time, the respect that you get for doing the right thing is worth it in the long run. So I just think as long as you think about doing the right thing and put yourself in the other person's position, I think that's the key to being hopefully a mensch.
So the other thing is that I consider you a very good athlete. You played basketball. You had many honors playing basketball for high school, and you're an excellent tennis player. So, and very competitive. So it's interesting how you are doctor, compassionate, father, community, compassionate, very, very humble. But when it comes to sports, very competitive. What's the edge? Why?
So I am completely not humble on the court. I'm arrogant. People hate playing with me and against me a lot of times. I feel like that's my outlet. And actually, the truth is, nowadays, I feel like I'm more an athlete than I am a doctor. That's the truth. The truth is, like, I do the doctor side on the side business, and I try to be an athlete, because what makes me happy is actually getting out there and playing and just being completely dissociated from the world. For me, playing tennis for that 1 hour, I'm not thinking about anything else. If there's any remedy to anything in the world, forget your Klonopin and your Xanax. It's getting out and exercising and thinking about something else. So basketball too is the same way.
So let's talk about the mind. So we got to bring sometimes back to the mind and exactly flow state. When you're in a flow state, you really are slowing down time, enjoying time, right? And you're playing a sport, so you're actually socially engaged. And when you're in that state, it's actually so healthy. What's interesting to me is what you just said is I'm very big on changing identity. So dad, I'm a dad. Captain of a boat, I can captain a boat. I could be a coach, I could be a doctor. But when I'm playing a sport, I'm an athlete. So when you're an athlete, you play like an athlete. You're not just playing tennis to hang out. You're playing as an athlete. Right. So that's very good. All right, so we're gonna get into a little bit more about us and our connection together as patient doctor and so, because you've helped also tons of my family members and myself and certain things that have happened.
Also, you might not remember, I'm sorry to
go ahead.
interrupt you, but right when I moved here like 15 or 18 or 20 years ago, the first person I called was Stephen Resnick, because you were already working in the hospital, Mount Sinai, and I wanted to get an idea of what it was like. The first person I called when I came back to Miami was obviously.
I appreciate that.
that.
I appreciate it. And
You remember that, right?
Of course I do. And the thing is with you and I also is that like we've grown up with each other from so many years that we could fast forward and there's no judging. It's just, I know who you are. We know each other, and no matter what, we know exactly where we come from and who we are inside. So if that's why I'm very comfortable with you. And every time I see you, I smile. I mean, all the time. We were running and doing things because I'm neurology, you're pulmonology. So we intersect many times, yet in the hallway we can talk and briefly and catch up. So Breathless Tales. So Breathless Tales is a book, correct me, right? That talks about your experience with pulmonary cases, right? Real quick, what is a pulmonologist?
A pulmonologist
Yes.
is a specialist of the pulmonary system, the respiratory system. So it takes care of things like asthma, COPD, lung cancer, pulmonary fibrosis, a whole range, and lung cancer, I mentioned, a whole range of pulmonary diseases.
Okay, and critical care. So you also have a specialty in critical care. So why does pulmonology intersect with critical care?
So in America, in the United States, critical care intersects more with pulmonary. In Europe, critical care intersects a little bit more with anesthesia. But the idea is that typically when people are really sick, they can't breathe, and then they end up needing intubation. And typically the people that are best at managing a ventilator here in the U.S. are pulmonologists. That's why the field of critical care sort of went hand in hand with pulmonary. In Europe, most critical care is actually run by anesthesia.
Okay, thank you for explaining. And so because here, many of the critical care patients also are on ventilators, and it's advantageous, right, for pulmonologists to be handling them.
Correct.
Okay, so what was striking is when I went through Breathless Tales, I got chills. I really did. I opened it up and I started going through the stories and fascinated because living in it, and it's 2020 and you kind of forget it, and then all of a sudden you start looking at it and it's mind-boggling what we went through. And what you went through is different than what I went through, because I'm going through it more now with patients that I'm seeing in my practice. And I was in it at the time because as doctors, had to do that. But you were really, really in the arena. I mean, in the arena. So I remember in February, all right, it was Super Bowl weekend here in Miami. And I was with my brother, and I took my son to the convention center. They had an NFL experience. My brother says, there's this virus in China. And I'm not hanging out here. When I hang out 5 minutes, I'm gone. I go, what are you talking about? He goes, no, I'm telling you, there's a lot of people in here. I'm out of here. And he left. This was early February. I thought what's wrong with him? I said, there's no virus. This doesn't make any sense. I didn't think anything of it. When I was reading in your tale, you actually were brought up a slide right when you detected. Do you remember, can you go through that moment and what you predicted?
Yeah, I remember I was speaking at the University of Miami. I gave a grand rounds to the Pulmonary Critical Care Fellowship. And my idea was I was going to put the 10 most important articles out and try to teach them something new. And that week, it just so happened, the day before, the Wuhan article came out from China about the Wuhan outbreak. That was the first outbreak of COVID-19. And they show on the picture of that New England Journal of Medicine article is a little electron microscope little dot of the virus. So I took a picture, I blew it up, and I showed the residents, the fellows, I said, believe it or not, this is like in January. I said, we're all talking here freely. In a couple months from now, nobody's going to be talking. Everyone's going to be talking about this one story. And I presented that. And it was like in January, and everyone laughed. I bet you none of those people even remember. I have the proof of the actual talk, the PowerPoint that I showed it, and I blew it up. It was cool. But the idea is, even our own infectious disease doctors, the heroes of really COVID-19, when it first started, I remember I said to them, I'm like, this is going to be huge. And they said, influenza kills 60,000 people a year. This is nothing. It's not going to be what it turned out to be, millions of people dying. So it was by a factor of 10 times influenza. But even the infectious disease doctors did not believe it in the very beginning. I was sure it was going to hit, not because it was prophecy, it was just because that's what was happening in China.
And also as a doctor, it's about instinct also, because you mentioned that in the book, is that you had an instinct about it, you had a feeling about it. Because you're not really somebody to predict something like that, as I know you. So you really knew that this was going to be something very unpredictable and something fast growing, right?
And to that point,
Yeah.
just to see how neurotic I became about this, because I'm not a crazy neurotic guy.
Right.
But the Johns Hopkins came out with the great website tracking the virus from the
remember.
very beginning.
Yes.
And they did a great job. They were the first ones to show, and they showed which cities it went to and how many people recovered, how many people convalesced already. They got that. I called up in China. I called up places in China and spoke to people in hospitals to try to figure out what was going on. When we talk about Mr. Chen, but I'm saying I called up hospitals to see what was the real life, what was going on there. And the funniest thing is I got on, I tried to go on Voice, the Voice app.
Right.
So I went to Chinese, because I can't speak Chinese. They answered
Right.
the phone, blah, 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 blah. And so I went on Voice, and I was like, are you having any COVID cases here? And then they're like, blah, 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 and then I would go, blah, 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 and I would talk
So
to them.
talk to them.
Yeah, that was how it started. I became so neurotic. I found one of the residents that used to work with her. Her name is Ying Min. And no joke, her name is
Yes,
Ying Min.
yes.
She was awesome. She was a great resident. I tracked her down, and I had her call up hospitals in China for me. And she did. She sent me an email about it.
So you're already tracking down in China. And we're going to get into that because it's amazing the things you do and the things you've done by just not just sitting back, but being proactive. So now the cases are developing, right? And where's the point where you started to feel that, okay, we're in Miami Beach, we need to talk to the hospital, we need to talk to the mayor. What take us through that time? When did you start feeling that this thing is really going to really hit as cases are coming in, or is it before that?
Yes. So once it was in China, so at that point we're just following it. But then once it hit Europe, and once you started seeing that, and we had a little WhatsApp group in the University of Miami had a little get together, a Zoom. The first Zoom I've ever been to was an Italian doctor talking about his experience. But once it hit Italy, you knew someone's going to fly in from whereversville. It turns out it was Washington State, right? The first case is here. But everybody knew it was going to hit. It's not like all of a sudden we're going to have a cure to this thing. So then I approached, as the president of the medical staff, I happened to be at that time, I brought it up at the medical executive committee. I said, by the way, the last couple minutes, the president has a chance to speak up. Otherwise, I was very quiet the whole time, just listening to everybody. But I said, we really have to think about this new virus. It's going to hit us, and it's going to hit us hard, and we have to have mobile testing. And that was like to start. A lot of the doctors sort of freaked out.
So you mentioned something about patient zero, and it was in Rochelle, New York, and visited or was in contact with people from this APAC convention. So you actually were able to trace the people with patient zero as they came to Miami. Is that correct?
Well, no. So they had an APAC convention, which
Right.
was known that that patient zero was at.
Right.
And there were members of our synagogue, Beth Israel,
Right.
who were coming back from the APAC convention. It was literally Friday afternoon that they came back. So what I did that night, they were supposed to be in synagogue. And I think they ended up coming in Friday night because Sabbath started. But I ran over to the rabbi's house, Rabbi Bixen. And it's very hard to tell a rabbi to now go, without any evidence, go up to the people that came from the APAC and tell them to stay home because they could have been exposed and they could bring it. So I told the rabbi, and initially he kicked me out. He was very forceful. How dare you tell me I can't say these? These are my longtime members. They support me. How dare you? Very mad. He's very, very good-natured. He cares about his constituents. But then I said, you're going to have everybody sick. It's going to be on your head. So what did he do? He actually went up to them. I think he even walked over to their homes and he said, don't come to synagogue. They were very mad at him. But then after the weekend, they realized that it was the right thing to do. They didn't, who knows? They could have been harboring it. We don't know how. And it could have been spread much worse because of that.
So you talking about social, so there's principles that I talk about, which you'll see on my Healthy Mind. There's 8 principles, and my 8th principle is social connection, using social connection in order for survival, because our brains really need social connection. You use this WhatsApp group with groups of pulmonologists, infectious disease doctors to communicate. So then you were talking about that you wanted to somehow not only take this group, but you yourself started calling hospitals in Wuhan, China, and you got in touch with a Dr. Peng. Take me through that, because you actually have on the tail the email sent to Dr. Peng, and he responded. Is that correct?
Yeah. So I sent him. He was the author of that article in Wuhan, the center. So if there's first of all, I was just amazed. How did this guy survive? I wanted to live, I'm like, all I want to do, this is the survival thing. I thought I was going to die. So I was like, this is the last couple months of my life. I really thought I was going to die. So I was like, oh, you know what? I'm going to do everything I can. I want to go out fighting, right? So I emailed him. First, I emailed him like 5 times, but then he responded. He's like, sure, at 10 p.m. my time will be 10 a.m. your time. And the University of Miami had put together the first Zoom I've ever been to on Italy. So I just had told them, oh, I have Dr. Peng, and of course everybody. And on that Zoom, it was the first time I ever did Zoom. I recorded the audio. I still have it somewhere in my house, but I didn't know how to record the actual Zoom. But you start seeing 10 people, 30 people, 50 people, like 100 people joined the Zoom. And I was like famous. I was moderating the questions. I still remember the questions. He kept on saying, well, I've never seen oxygen levels this low. But I remember there was one thing telling. First of all, it was a very smart University of Miami doctor who brought up tocilizumab, which is a rare medicine at the time. And she was really prophetic because that turned out to be a positive medicine. And he said he didn't have experience with it. But one of the interesting things was when I asked him, I said, so what works? There's got to be something that works. And I remember he looked at the camera and he said, nothing. And that was like, once he said that, I think everybody in the audience was like, oh, Shrek. We're screwed.
We are screwed. We're screwed. I could just imagine with all the top pulmonologists in South Florida and then growing in different countries in Europe and then being exposed to a pulmonologist or doctor that's in Wuhan, China saying that there's no treatment. Yeah. That's a big problem.
Yeah, that was scary.
That is a very big problem.
But to that end, the Chinese came out with also their protocols in Chinese, and on the internet you could translate it. So I was translating their protocols as they were being updated. The things like they were using.
So you mentioned survival and going out fighting. So that's principle number 1. Principle number 1 is that we're wired for survival. So we are wired for protection, survival. So you went on survival mode, and I'm such a big believer of during COVID you can see so many people that went into survival mode and growth mode and use COVID for their advantage. Were they able to learn and grow? You use it for survival, although you were able to use it as a power to help the community. I mean, there's no question, Ari. And the things you were doing. Now, one of the things that was...
Can I interrupt you with that statement?
Yes.
Because you'll love this.
Yes.
Michael, you'll love this. This is an amazing story.
Yes.
Stacy. There's a lady named Stacy who I love.
Yes.
I love her. She was working at this place called BioCollections.
I was going to get to that.
You're going to get to that.
I was going to get to that.
Can I tell you? Because you talk about survival and making it to your benefit. Okay, sorry.
No.
I didn't know you read that.
I read that story. Of course I read that story.
That's my favorite story.
Because that story is going to bring my attention. All right, so that's the thing is that this is for the testing, right?
Yeah.
Okay, so go ahead. You know what? Tell the story, because the story is actually mind-boggling. Go ahead.
It's mind-boggling that the United States of America failed. When COVID hit, the biggest failure was the patients that came to the hospital, we couldn't diagnose them. So imagine you have a disease, you're not sure what they have, so they're stuck, and then you send them home, and they probably have COVID because you never were able to test them. It was ridiculous. And I kept on calling the pathology department, how come you don't have the damn tests already? And then finally got a test that you need to send it out, and it gets tested in Atlanta, blah, blah. So Dr. David Mons is a friend in Beth Israel. Talk about social connection. He reached out to me. He said, I think they have this place, BioCollections in South Miami. They're already testing somehow. They found the same thing that they're using in Atlanta. So I was like, I drove down there terrible neighborhood. And in fact, people came up to me like to rob me, and I was wearing my suit for COVID. So I pretend I was crazy. I was like, whoa, so they avoided me. I pretended I was nuts. But she came out, Bio Collections. Her name is Stacy. They used to do porn, people for porn. What are they called?
Adult stars.
Adult stars.
Yes.
They used to test them for STDs.
Right.
So talk about, using and pivoting. They pivoted and they said, you know what? We could test for COVID. And they were not only good, they were awesome. They were accurate. And they grew like this, but Stacy was a real hero. She worked for them, and I would call her up, and she would just come out. People would come. All the rabbis. She used to see porn stars.
Uh-huh. What a
Literally
transition.
a week later, she's
Right.
seeing all the rabbis from 41st Street in Miami Beach.
Right.
She's testing their nostrils. I mean, from
one
below. All the way above in 1 week. I mean, the irony, I kept on telling her, I'm like, oh, how does this feel for you? And she would commiserate. She would tell me like her fears, her cases, and we would speak a couple of times a day. Like I was like best buddies with this Stacy, who I never spoke to afterwards.
Well, easy with the bad. Okay. So,
It's funny.
all right. So that was the basic thing where you found and able to use an adult STD site in order to test for COVID with efficiency. And then how about the second thing? So how about the story about the mask? So I get a patient of mine puts me in touch with this guy. He texts me out of nowhere and he says, Dr. Resnick, I have access to 3,000 N95 masks. Can I get them to you? I said, absolutely. I said, at that point, there was no PP. We had nothing, right? We had nothing. We had a little string and we were fighting on the internet, and the hospital was also conserving the N95 mask. So I get in touch with this guy, and he puts me in touch with another person from the warehouse, and believe it or not, I get 3,000 masks. I contact you and I go, I got 3,000 masks, and I contact the hospital. The hospital wasn't at this point, because of the mask, have to be checked whether they're able to, whether they were 95 masks. There was going to be a whole protocol. So we said, you know what, let's just bypass this. I'm going to donate 1,000 to pulmonology, 1,000 to infectious disease, and 1,000 to the emergency room. And that person, what you're going to talk about, is the antithesis, right, of pulmonary. So, well, don't explain it because he wants to be. We could describe Ryan. Well, we could describe his name. His first name is Ryan, okay. And somewhat who he is. Right. So explain why is the antithesis of pulmonary.
Right. So the story is actually that we didn't have N95 masks easy. Right. And the hospital had this. The hospital's amazing, and I love it. But for this, I was very upset because they made you wear these special green ones, right? So you gifted me the best gift I could possibly imagine: 1,000 N95 masks, which I used the whole pandemic. I would go through, at first one a day, and then eventually I figured out you could wear the same one, for weeks at a time. But it saved my life. It really did. So I owe you a debt of gratitude, really. But the person who gave it to you never told me. You said, "Oh, I don't want to give you." He didn't want to give his name or whatever. So you never told me his name. Fast forward to, this is just incredible. Fast forward 2 years later, or a year and a half later, when the vaccines were available, and you could only get it if you had a high risk, if you were a high risker. So people were dying to get the vaccine. Like literally, if they had high risk, they really wanted to get it. So you called me up. You're like, you won't believe it. The guy that donated me has a high risk, and no one's giving him a vaccine. He needs a special note from a pulmonologist. So I'm like, hell yeah, please let me finally pay this guy back. So it turns out his name was Ryan. And then I asked Ryan. Ryan really had a high risk condition, but what do you do? Turns out he's like the head of an e-cigarette company, which, if you know pulmonary, even though e-cigarettes help you get off of smoking, but it's still like a villain, so to speak. E-cigarettes, you're hooking kids on nicotine. So it was funny that my hero really was technically a villain, which I never looked at it like a villain. I actually like e-cigarettes, but for getting off of smoking, but still, that's the irony.
That is the irony. It's amazing how people, where you don't think of the people that are looked down maybe on society, are the ones stepping up. It's incredible.
And he specifically was brought to trial by the U.S. government. This specific person was really vilified. And it shows you that he really was a nice person, and he really meant well, and he's trying to help people. It's funny that he was vilified.
So I remember there's so many things with you that I remember because you had a specific outfit, and you actually were in the New York Post, or was it
New York Times?
In the New York Times, they actually had an article that talked about something that your outfit or the way you use PPE. You looked like a big blue Smurf. And you had the whole gear, and everyone, because you're tall, we can point you out immediately. And you had a regimen that I was reading about, which was very interesting. Not only with the PPE and the reusing PPE, you were also swishing iodine. You were gargling, right?
Yeah.
Listerine, was it? And you were also diving every day in the pool, chlorinated pool.
Yeah.
Explain to me this ritual that you were doing.
Yeah, so every day I would start the day with my quercetin, which now I don't believe in, but at the time I did believe in it. I'd start with my Plaquenil. In the beginning, I had my Plaquenil, my quercetin. But really more than that, I think the Listerine gargles, I still believe in. I mean, think about it. You wash your hands with Purell with 60% alcohol. Listerine is 60% alcohol. So coronavirus and all viruses, they live in your oropharynx. So it makes sense if you gargle long enough, you could probably kill some bacteria back there. That's all the thought is. It wasn't, actually what I did was worse than that. I did iodine because there was an early study that iodine helped. So I put like 1 cc of iodine and 9 cc's of water, but I mixed it and I gargled. That tasted gross, and I spit it out. It turns out there were companies that tried making it public afterwards, but whatever, it didn't go well with those companies. But Listerine was my thing, and then after I would round in the COVID ward, I would jump in a pool because you're cleaning out your sinuses with the chlorinated pool. I still recommend it for people that, let's say, had an exposure to some virus. What else is there to do? You could clean out your sinuses and you could rinse with Listerine.
I mean, you're so open, and because at that time, right, we're not even talking about vaccination yet. So at that time, we're like looking for vitamin C and zinc, but the person to go to was you because you were so up to date on figuring out what to do because it was complete chaos because we didn't really know what to do at the time.
Right.
So take us very quickly, because there's a lot of other things I want to get through, but take us quickly the treatments that evolved, real treatments. So like convalescent plasma was the first, right? Somewhat, then were monoclonal antibodies. Then we got into remdesivir, and just take us through a little bit, just not specific, just a little bit of the timeline, roughly, of what worked the best early.
So first of all, I'm talking big here, but I have to also, the infectious disease team really spearheaded a lot of this, if not most of it. And Dr. Golder, who was the CMO along with Steve Sonnenreich of the hospital, they were very instrumental in being open-minded, which is really incredible when you compare our hospital, our little dinky hospital, compared to huge university centers. We were using things that other places weren't using. And people were calling us from big-time places saying, hey, what are you using? Because we were open-minded. Our infectious disease doctors pushed the envelope. We pushed the envelope. And people respected it. So bottom line is, like convalescent plasma, when it was started in New York. And it evolved over time. There's a main author, his name is David Sullivan he's from Johns Hopkins. I spoke to him about, we were going to be part of his trial for convalescent plasma as it evolved later on, but we ended up not going into it. It was a positive trial. But convalescent plasma was the very first thing. Basically, somebody who had the infection has the antibodies in their blood. You just inject the blood into a person. It seems very obvious that might have an impact, but of course it really didn't. I was the PI on the first cases because it wasn't perfected. We didn't have high antibody levels in the first convalescent plasma. It was a work in progress. Eventually it would work, but by the time you have other better therapies, so it's out of the wayside. It will be in the next pandemic, the very first thing that people will do as well, convalescent plasma. So it's a good process that we're going through and perfecting it. David Sullivan et al., like you could look at him. But bottom line is we started with the convalescent plasma that failed, so to speak, and then the things that worked were tocilizumab, which are anti-inflammatory medicines. The best medicine of all for COVID by far was Regeneron's monoclonal antibody that first came out, and then Eli Lilly came out with bamlanivimab, something similar. Those were monoclonal antibodies. The very first miracles that you saw with COVID really happened in September, months after the convalescent plasma was played around with, because that was incredible. I had patients, literally, I still remember this lady on the phone at your father's house playing tennis. Your father saved my life because I got to play tennis every day there for whatever. And I'm at your father's house, Jimmy and Lydia's house, and then I get a call from a lady. 18 days, the most severe headache. She's can't get out of bed. The husband is crying to me on the phone. The monoclonal antibody just came out. We had access to it at Mount Sinai, and you only can get it if you have the first 5 days. I called up the hospital and I begged them to do it, and they were always very nice with me. And we got her in. She had she had the monoclonal antibody Regeneron. 10 minutes later, completely fine. It was the most incredible medicine I've ever seen because it was a real antidote to the problem. And then it evolved over time. The coronavirus, evolved, and then it doesn't work anymore.
So, what the thing about COVID also? So I spoke to you about it. Is that I really learned. I have a lot of lessons that I talked about, and when I finish my book, hopefully at the end of this year, is a neurological perspective of how COVID has changed my practice. It's changed your practice, obviously. I really learned that COVID was an inflammatory condition because I talked to you about this, is that it harbored people that really had inflammatory conditions like diabetes or metabolic syndromes. Obviously, put the patients that had weak immunity systems, but who were the people that you noticed were getting sick the most? Was it young athletes? Was it people that had no risk factors? What type of people were getting sick with COVID?
Yeah, so but in the most part, we used to say, "Oh, this is what's it called when you discriminate?"
Right.
I said this is a discriminating disease for fat people. This disease hates fat people because everybody was fat.
Right.
BMI definitely over 35. Like they were going to do bad. Like even if they were young, they were going to do bad. There's a celebrity. There's a well-known celebrity. He'll never know, but I helped save his life because he was a huge BMI, and he would have gotten really sick. We got him monoclonal antibody. Otherwise, he would have had a problem. Most people at that point with the bad virus, the Delta wave too, like really bad, they were sick. But doesn't mean everybody. The majority of fat people did fine.
Right.
In the hospital, we see this skewed. We see the 10% of people, but they're all fat. Right. And they did bad. Occasionally we would have some people that were younger that got really bad cases of COVID too, but they were the minority, a lot of them HIV, so there was some immunodeficiency related.
And even the uncertainty, so this is where I get into uncertainty because it was so different. This was the crazy thing about it is it could be diarrhea, abdominal pain. It could be anosmia, right? A loss of taste and smell. That was actually my first symptom when I got my first COVID. I remember that I got vaccinated, which we're going to get into. And months later, I went in a ride share. I'm not going to tell you the name of the ride. And the driver was coughing his head off. And I remember getting out of the car and going to dinner, and I looked at my brother and I said, "Oh my God, I think I'm going to get COVID." 2 days later.
I remember that. Actually, I remember that.
2 days later, boom, I got COVID. 2 days or 3 days. I really didn't. It's funny because as a doctor, you are able to recognize other people, but when you have it, I was a little run down. I felt fine. I went to work. But what got me was actually my son was eating a burger with onions, and I looked at him and I go, "God, it's weird. I don't smell those onions." I opened up the burger and I couldn't smell it. Yeah, I go, "That's a little weird." I ran upstairs. I put cologne on, and I go, "Oh my God, I don't smell it." So that's the only symptom I had. So I remember going to the ED that night. And I said, "Look, I can't smell it." And everyone laughed at me. They're like, "Oh, you don't have COVID." I go, "Look, I felt a little runny. I didn't have a sore throat." I go, "I think I got COVID." Of course, I tested positive. And I was fine, but I had to follow the protocol.
You got the monoclonal antibody?
And I did get at that point, because your recommendation was to get the monoclonal antibody. So that helped me speed my recovery, although I think my symptoms were mild at that time. But what's interesting about it, which I was getting into, is the uncertainty of the condition because it was so different more pulmonary, right? More fatigue, more fever. I mean, more body aches. Seizures were present. There were so many different. I had a patient came in for his neurological perspective. He actually came in because he didn't even know how to put his pants on. He became confused. And that was his presentation. I remember they called me as a stroke alert. The guy was pumping gas and didn't know why he was pumping gas. They brought him in, it was positive for COVID, and everything came back negative for stroke. So the thing is that the presentation was so different for everybody. So I guess everything at that point was pretty much COVID, right?
Everything. It was COVID until proven otherwise. At some point, everybody who was in the hospital had COVID, or you weren't in the hospital. So it sort of made it easy that way.
All right, let's get into the vaccine. So this is the vaccine now. Now we're moving along with the vaccine, and hey, there's a vaccine coming out, and we get the vaccine probably the same day, very early on, because doctors, and I truly believed in the vaccine at the time, because we're doctors, we're in the forefront, and I felt that there was two ways to really get, either you're going to get COVID, it builds a natural immunity, or you need to be vaccinated. So if I never got COVID at that point, I figured I'd be vaccinated. I did predict that if I was healthy enough to go through it, I would be fine, because I feel like I kept myself healthy and I live a healthy lifestyle. So I was kind of confident, but I also had to be proactive in medicine. And you mentioned something to me the other day. We were briefly talking that heroes and villains. So this is where I think it started to get a little, when that vaccine came out, it was like, doctors, what are you doing? And villains, and the whole vaccinations and all of this started to get, and even later on, it felt like, why are you guys getting vaccinated? And there was a whole thing with the vaccination. Is this correct?
I mean, just in a
Yes.
brief nutshell,
Yes.
it's incredible, because COVID is clearly different now than it was in 2019,
Exactly.
2020. But everybody thinks that, it's the same COVID. No, it mutated. So now, even though I just had COVID about a couple of weeks ago, I was out for 3 days. I couldn't move, but I wasn't nothing like 2019 where you're like, you could die from it. But people are like, these doctors, they were just hyper exaggerating for their attention, and these infectious disease doctors wanted it for their business. I mean, it's so far from the truth. Millions of people died. I mean, literally, you could find, a lot of people lied and they wrote COVID-19 when they just had it and they didn't die of it, but at least 500,000, a million people died, whereas, like I said, 50,000 to 60,000 a year in the U.S. die from the influenza. So, I mean, it's real, and it bothers me a lot when people are like, you guys were hyper-exaggerating. No, it was real. And at that time, you're right, it just totally changed the way it is now.
I mean, Ari, I remember, obviously you're just, I'm just bringing up things that I remember, because when you're in it and you get somewhat immune to it, I guess we use the word immune because you're in it. I remember going to the floors, and really it was absolute chaos. I remember infectious disease doctors exhausted. I mean, what they did and that crew did, I just remember all of them giving everything they had to take care of patients and stepping up. I remember going in the ventilators and putting them. Talk about that really quickly, just about the ventilators.
Yeah,
at one point,
what did pulmonologists do? What did I do? I mean, I was brave enough to go in the room, but really my intervention was, let me flip the lady around, the 500-pound lady. I'll flip her around and I'll bang her chest, and we'll see her oxygen levels go from 50% to 80%. I think that's our limit. And then eventually the heroes came in also, including Steve DeBeer, who's one of my favorite heroes of all time. I mean, he went in when shit hits the fan and your saturation is 50%, even though you're flipped upside down like a pancake. Steve DeBeer comes in, not afraid of anybody, not worried, just going to do the right thing. The man is, I'm telling you, he's really...
Who he is, what kind of doctor?
I'm sorry, he's a cardiothoracic surgeon. Okay. And he would cannulate, he would do ECMO. When nobody was doing ECMO, he was the first one who did ECMO in Miami Beach in South Florida. I know that for a fact, because our lady, and she's on national news, Isabel Pupo. She was 350 pounds. We couldn't get her oxygenated. I called Steve DeBeer, and Steve said, there's no way I'm doing ECMO on a 350-pound lady. I said, Steve, this is who gets COVID. I still remember the call. He's like, there's no way I'm doing it. Okay, I'll be right over. I still remember. He came over. It took him 4 hours by himself. He went in the room and got the x-ray. He was there. I was there just to support him. I stood in the room, but I didn't do anything. He cannulated everything, saved her life. She was in the hospital for like 190 days. She came out of the hospital. She's totally fine now, totally fine, off oxygen, living a normal life. But those types of things. All we did really is try to figure out the ventilator, the best way to keep people alive so that if they could somehow withstand it, then they can get better.
Now, remember, Miami was a hub. I mean, we were seeing so much COVID and really sick COVID. So we got to understand it. The hospital was so busy. Looking back, I just remembering, it was pretty horrific.
The most horrific
yes,
time, people don't realize it, was actually after the vaccines came out. February, March, when we had the Delta wave, people still, like you said, the villains, the doctors are villainous trying to get you the vaccine. They didn't take the vaccine. Those are the ones who got really sick.
Right, and that's the other thing. Now, let's go into that one person that, unfortunately, I remember one of the doctors, I won't get into specifics, but one doctor, same round, probably the same day we got the vaccination, developed a autoimmune type of thrombocytopenia. The platelets were dropping, and I was called as a neurologist because he suffered a catastrophic intracranial hemorrhage, bleed in the brain, and unfortunately passed. And the question was this vaccine related? And I truly believe it was. We're not going to get into details on that case. I just want to I remember you, because this is who you are. I got to make sure people understand who you are. You called, you went up to the National Institute of Health, or what did you do to say, we got to figure out what's going on and make sure that the vaccine is safe? I need to report this case.
Yeah, it was the same day I got my vaccine also. I called the CDC, the Vaccine Adverse Reactions Hotline, and I made a report. And they called up. No joke, we had a Zoom with the head of the CDC, Birax or whatever her name was. I was on the Zoom call with them, and I explained the case. And they presented, I still have the emails, they actually took the blood of the patient, they took the spleen, and they sent it off to a laboratory called the Resnick laboratory in Atlanta. They proved that it actually was not vaccine related. It was thrombocytopenia not related to the vaccine. You know, that's how they proved it. Whether or not you could believe the CDC or not, they did send it to the lab, and they showed me the documents. They sent it to me, the form. So I think that there was proof in that case that it was ITP, which is idiopathic thrombocytopenic purpura, but nevertheless, you know, you have a temporal relationship to a vaccine. I was one of the people that published an article on vaccine-related myocarditis, a lady who died, that we proved that it was from the vaccine because it was a biopsy of the heart that showed it. So I'm not against showing if something is vaccine-related, but the vaccines did more benefit than harm.
Exactly. So that's the thing, is that you want to take a point of this one case and just, obviously it's very rare, and the incidence of ITP is very rare, and they did prove it. It's just people have to realize how much the vaccine actually helps.
Oh my God, yeah, it saved. The Albert Bourla, for all the crap he takes at Pfizer, he saved millions of lives and should be blessed.
So I'm going to tell you a little story about COVID and what the Delta. So my grandmother, you know, she's 96 now, she's kicking, doing very well, thank God. And when she got the Delta wave, COVID, and I remember that she had a cough and she was sick, and 2 weeks later, she developed symptoms consistent with a stroke. So she actually called me. She says, "Stephen, I think I'm having a stroke." Diagnosis right on point, called fire rescue. I drove immediately. I met her in the emergency room, and she indeed was having a stroke. She was dysarthric. She was slurring her speech. She was ataxic. The episode and the symptoms happened so quickly that we gave her TPA. I called my associate at the time because it's kind of strange taking care of a family member. I want a second opinion because this is your family. He says, give it. I asked him. He says, give it. I remember getting the CT scan, and then the CT scan was negative, and the CT perfusion, which measures how much perfusion or blood flow to that area, what we call penumbra, showed a large area in what they call the cerebellum. And I gave her the TPA, and you can see that an artery, or the vertebral artery that feeds that, actually was somewhat occluded or stenotic. And she comes out, and her symptoms are worse. I'm like, oh my God, I think she might be bleeding. So I said, oh my God, this is my grandmother. What am I doing? I go do an MRI, and she gets the MRI done. And I get the MRI done, and the perfusion was this large, and the stroke ended up being this small. She comes out asymptomatic completely.
Yeah.
I knew she was good because actually she, as per protocol, she still has to be ruled out because she just had COVID. And she starts yelling, "I'm not going to the tuberculosis floor."
I saw her. She was in the SICU bed 12.
Yes,
Yeah.
exactly. So they
That's
put her
funny.
in the COVID floor. And she did not have COVID because she was already 2 weeks later. But I'll tell you the story behind that for me is that I'm going to give you the most rewarding thing is that my grandmother, in our tradition, is that our grandparents pay for medical school or school. So she gave me school education.
Amazing.
And this is something you pay her back.
That's incredible.
And not only that, I started the stroke program and just knowing how fluid and how everybody stepped up and how everything went well. It was just a great opportunity for me to say thank you to everybody that was involved. So
That's incredible.
That was an amazing story. That's kind of a positive story around the COVID experience.
Oh yeah. By the way, that is a big thing about mind over, like what differentiated people that made a miraculous recovery. Like I think about that. Like there are certain people that I could think of, and they're okay with me sharing their names. I mean, they've all written books about their recovery. Like I think of this man, Guillermo Garcia. I think of Barbara Garrido. I think of Dwayne Cochran. I think of Matti Korf. These are all people.
How about he's very vocal as well, the Mexican singer.
Yes, Antonio Mori. They all have written books. What differentiated them?
And he was, I mean, I remember him and seeing him in the hospital. He had a little bit of a neurological issue. It's incredible. I mean, I did not think...
Well, he's a holy man. He was the holiest man I've ever met in my life. But besides that, what made these people... I was always thinking, like, what is it? And the truth is, talk about minds. Like you talk about the healthy mind, the mind of a person. But I do believe that there is a transfer of... If I care about Stephen Resnick, guess what? You're better off. My care helps you. I promise you, I really feel this strongly because like Matti Korf, his wife, Adina Korf, she was on the phone with me literally 24/7. When I say 24/7, every hour she was thinking about him. What can I do? What can I do? Vanessa was the wife of Guillermo Garcia. Every single hour that this guy was intubated, sedated, the worst things you could imagine happened to somebody, she was on the phone with me. The care that she had somehow transmitted. I'm not saying people, God forbid, that passed away, they didn't have the same care. There are other things. But the one thing that I noticed of these people that had the most miraculous recoveries, like this Barbara Garrido, like you look at her CAT scan, you're like, there's no way. Her husband was distraught and calling. And I just remember them being so annoying that it transcended, annoying in a good way, that I think that healthy mind is not only of the person, but you have to surround yourself with people that really care about you, that genuinely care about you, because ultimately you're going to need all that support.
And that's the principle of social connection, and being family is so important. You're very much a family guy, as much as I'm a family guy. And there's got to be, inside that subconscious mind, there's got to be purpose. There's got to be a purpose. You know, you live your life without a purpose. You're just aimlessly or mindlessly. You really got to live a purpose. You got to have faith. You have to have faith. And we're going to talk about your faith too, about your injury and how you got better. And actually let me bring just a little back to the COVID story. I was going to tell you something is that when I talked about Ari Cement, is that you're the guy, I'm telling you this, I have to do this because you're on here, is that you're not billing people. They took advantage. Like they're calling you on FaceTime. I remember the thing you would do is put a pulse ox to measure the oxygen, have them walk, check them out, order medication for them, not worrying about the legality, worrying about the billing. You had billionaires, because I know them, come up to you and give you, like you said in the beginning, offer you different things. And you were so humble, and you also just ethical, because you did this to help people. This is a doctor. This is where I with the new residents and training and students, this is what I want to teach, is the compassion of being a doctor while we're in it. And we're not robots. We're not ChatGPT robots. We need this empathy and connection with our patients.
Yeah, the only correction I would say is that I'm not humble. I'm not humble. I'm not arrogant, but I believe in myself. Like I wouldn't say that I'm. I wish I was humble. I wish I was.
That makes you humble
but
by saying that you're not humble.
No, I do it. I like the gratitude. I like it. I don't consider myself humble, but I consider myself always doing the right. Like I always try to do the right thing. Everybody makes.
Well, you're doing the right thing, but also I think you're very confident.
Confident. Yeah, I believe confident. Confident's better.
Yes.
Confident, but not humble.
Not humble. You're very confident.
I could be humble.
It could be humble. So as a neurologist, which is central nervous system, peripheral nervous system, and that autonomic nervous system, which a lot of doctors and people don't realize that the neurological system is not just brain or spinal cord or nerves that exit out. There's actually an autonomic nervous system, and there's a brain stem that controls breathing and our respiratory drive that's located in the medulla and the pons. So I want to talk about the connection between brain and lung. So we got brain and lung together. And let's talk about, there's so many little different conditions, from sleep apnea to other conditions like hyperventilation syndromes and things like that. But let's talk about the breath-brain connection. As a pulmonologist, let's go into this because you're a clinical pulmonologist, right? Patient comes in, correct me,
yeah.
And you got the lung. You're looking at that lung. It could be COPD, asthma, emphysema, right? All these conditions of the lung. Let's take it out of the lung right now, okay? Because there's so many conditions. So, like as a neurologist, I can see so many conditions of the neurological system. Parkinson's and Alzheimer's and so on. So, but let's take it back a little bit on the, I want to say holistic approach or just understand. Let's talk about a little bit in your training, like as a doctor, because this is what changes over time for me, is that I was so into, like as a neurologist, really being able to come up with a differential diagnosis and talk to patients and just come up with that diagnosis. Then I started to learn things that I never learned in medical school and residency about consciousness and about your subconscious, about the mind, about these networks in the brain. I actually had to start studying that on my own. Also, we share a little bit with psychiatry and psychology, but it's the same organ. I talk about that all the time. Let's talk about breath. So do you really learn about breath itself, besides the connections, but about breath work, how to calm a patient down just by breath work?
Yeah, we actually don't. We certainly don't in the Pulmonary Critical Care Fellowship. Okay. I'm actually a fellowship director, and actually now that we're talking about it, we probably should. There are certain conditions that we do. There's a thing called active cycle breathing. If that's what you're referring to, that's for bronchiectasis. So when there are irregular dilatations of the lung and mucus gets stuck, you can't just cough, because when you cough, you actually make things worse. You take the mucus that's supposed to come up and out, you shoot it back in, further in. So active cycle breathing is something like this, where you have to train your mind, focus on your breath, focus on the breath in and out. Don't try to cough with your glottis closed, which is the normal cough, but it's actually trying to go like this. Like that. That's the only time we talk about breath and mind. Is sort of like in bronchiectasis. Also, emphysema is another condition where you're also training the patient, where you say that you're probably better off if you close your mouth and you extend the exhalation phase of a breath. So that's the only other time we talk about breath. But in terms of what I think you're driving at, which is the healthy breath, sort of like healthy breath mind, is focus on, oh my God, I'm breathing, relax, calm down. Like so much of pulmonary embolus, a lot of conditions play with your mind, and we don't do a good job. I don't know what the right way is to do it.
Right. So that's something that I started to learn so much about, and we can talk about it. I'm going to bring people about like neurodynamic breathing. But it's so important that for me, which I never thought I would do, is when I start to meditate in the morning and at times before I go to bed, and I start learning the breath work, or when I get into the ICU like on a weekend and I'm like, oh my God, I'm here, and then there's so much going on. I actually go to close the door and I focus on my breath. I reset. One of the things about breath work is that there's a connection of the parasympathetic nervous system and it affects the brain waves, right? So we have this electrical system in our brain, and what it does for me is that I know and I can play with focus, which is beta, which is a frequency and of the brain, and then I could actually go into what they call alpha, which is a posterior rhythm, and theta, and be able to go to alpha, theta, bouncing into those states of creativity, into focus. Because the key here with breathing is that I look at breathing as almost focused attention, dissociation, and then being able to clear my mind just by breath work. That's why it's so important as a pulmonologist that we to discuss these things, because it's not just the disease process, it's also the patients, because asthma and all these other conditions where specifically, like a lot of cases you see, let me ask you this question. Do you see cases of, how often do you see patients that you really don't understand that could be what called functional or maybe psychiatric, like part of your practice, x-rays normal? Is it a lot of patients?
A lot nowadays. I don't know, with the generation.
So what kind of symptoms are you
Younger
getting?
patients by and large. If you're seeing somebody less than 40 for shortness of breath, more than 50% of the cases are psychoneurogenic. They're not, you don't find anything, and they turn out to be something like that.
Right.
And actually, that is what I recommend. Deep breathing exercises.
There's diaphragmatic
incentive
breathing,
spirometer.
there's box breathing, there's all these different breathing exercises. I think breathing practice, I'm going to have a whole talk on breathing. I would love for you to come.
Yeah.
I'm going to have a specialist talk about it and get into all the neurodynamic breathing. But there are a lot of conditions that affect the brains because of that sympathetic nervous system, that amygdala firing, and then causing the nervous system to be out of whack, or what I call sympathetic overdrive. So what happens to the bronchioles, right, during that stage is what? Is that, so a lot of times explain to us what happens to the lung system during fright and flight versus rest and digest? What happens during that?
You mean the sympathetic
Yes.
nervous system? So what happens to the lungs? They bronchodilate.
Right.
That's why you use albuterol as like a...
Right, and that's how it happens. Is a lot of times, like today, I saw a patient today who came in for tremors, and he noticed the tremors would get worse with albuterol, which is a sympathomimetic drug. All right, so that's where the connection of the mind or brain and lungs come in.
I'll mention, just to
Yes.
have the Jewish aspect,
Yes.
Jewish aspect, that death is actually defined as a permanent cessation of breathing. It's not actually cardiac, but really, if you can't breathe on your own spontaneously, that's the definition of death. That's why also the lungs have 18 bronchopulmonary segments. There are 18, which is sort of interesting because 18 in Hebrew is chai. Chet yud is the letters correspond to numbers, and it's 18. So life is really within your breath. And that's a very important part of.
Well, that's the other thing we come in contact is critical care. I get called for anoxic brain injury, and then what that is basically is that there's loss of oxygen or blood supply to the brain, and the neurologist assesses whether the patient is brain dead, because people think that there's death is when your heart stops, and unfortunately, there's two ways: either your heart stops according to Florida law, which is cardiac arrest, cardiac death, or brain death. And so the way we do that is we go through that whole brainstem. And the last thing we look at, because you go through all the cranial nerves, is that respiratory drive. And we turn off the ventilator. We do an apnea test to see if there's any breath. So that's exactly right. So if there's any type of spontaneous breath in there, the patient is considered alive. Correct?
Right. Exactly.
All right. So let's get into now our relationship, which is a crazy story. As a patient doctor, because you're a tennis player and you're playing tennis and it was wet surface, you slipped and you suffered a fractured radius, right?
Yeah.
So fractured humerus. I'm
yeah.
sorry. You had a fractured humerus. Explain what happened and being a patient and what's going through your mind. And we're going to really kind of talk about this.
Yeah, it was incredible. It was right before Martin Luther King Day weekend, not this year, last year. I was playing tennis with a very good friend of mine. It was 12-12, and I purposely went on the side with the puddle because I thought I was better than him. And it was 12-12 in the last point that we were playing points. and he hit the ball towards the puddle, just, because you're trying to win, but I don't think he thought about it. And I jumped in the puddle, I slipped back, and like a handcuff, I went back on my humerus. I'll send you the picture. And I fractured it mid-shaft humerus right away. I couldn't feel my whole hand, and basically I was paralyzed. Turns out I was paralyzed my whole left arm for over basically almost a year, 6 months definitely, where I couldn't move. And the prognosis initially was I went to see Stephen Resnick, and you did an EMG and a nerve conduction after the first 3 weeks.
Well, explain. So,
radial nerve. I'm sorry. What happened was the humerus split in half,
right,
and
so
not only that,
a fractured humerus, right, which for the radial nerve was right underneath it, right, and then you had a radial nerve palsy. You had surgery.
I should have said the nerve. 15% of the time, when you have a humerus fracture, even the radial nerve is right by the humerus. 15% of the time, you can get this neuropathy. It's called neuropraxia, where you lose control. But 85% of the time that gets better. But in that 15%, even 1% of the cases, you have an entrapped radial nerve where the nerve is stuck in between the two bones. So, of course, my luck, it was Martin Luther King Day weekend too, so I couldn't get a surgeon for the first 3 days. 4 days I had to wait. The nerve was actually entrapped, and it was getting rubbed on in between the two bones, and it was severely contused. And when she saw it, she saved my hand, Dr. Stephanie Shim, but she said, I'm not sure you're going to really have a recovery, and you should go see a nerve specialist and maybe a tendon specialist. That was even right away.
So I examine you, and I say, look, Ari, you got a triceps, which is one of the branches from the radial nerve. And then I actually saw you had somewhat a brachyradialis. So I was like, okay, this is good. And I said, oh my God, you know what? It could be, right? A possibility that the nerve might be also entrapped in the posterior neurosseous nerve, which is a branch, right? A motor branch right off distally to the radial nerve. But take us through the slow growing process of being a patient and being paralyzed.
It was the worst. It was really the worst. It was much worse than COVID for me. I just couldn't really do anything on my left hand. I couldn't put on gloves. So here I was a fellowship director. I literally took me 5 minutes to put on a glove. I was able to flex, but I couldn't extend. So I actually still did procedures, because I was able to lift it up, so I was still able to do stuff.
So radial nerve injury causes a wrist drop. So the wrist it has difficulty with extension, and then the fingers are dropped, so you can't extend the fingers. So that's the problem. And then moving this finger inside, and somewhat the muscles here also, which are the extensors compartments, that's what's involved. So there's a very slow growing process how it all connects. But take us through prognosis, what the doctors were telling you, because you've seen the top doctors, you've seen me obviously. Yeah. So to discuss exactly what the mindset was on your end as being the patient.
So when it comes to radial nerve, almost all the doctors say, oh, it's going to be great. Radial nerve always comes back. But I, of course, was in the question mark. The worst thing is if you know you're screwed, that's okay. If you know you're screwed, you can get some corrective procedure. If you don't know which way it's going to go, that's the worst. That's in limbo. I was in limbo. And so for 5 months, every day I woke up looking at my hand and saying, oh my God, am I doing it? I actually had dreams. I would have a dream that my hand would go like this. Imagine 6 months go by. I feel bad for all the really disabled people, how they go through it. And really talk about heroes. These are people, somehow they get through life. It's very hard. I was severely depressed. I started taking Celexa for a little while. Here I was the most confident, guy in the world, and I couldn't put on my shoes. It was very hard, and that's right after all this drama I had with COVID and all that stuff, and coming right off of that, it was really hard. It was the hardest thing I ever had to endure.
Right, and I gave you, remember, so we talked about it, and there was a lot of emotional part of it, and to give you a goal, right? Because I told you 6 months. Some doctors said 3 weeks. I told you 6 months, right? And so I gave you that goal, and you got to that goal. And that last thing, talk to us about the recovery. Do you notice also by looking in a mirror? What did you do?
Oh, so I want to talk about that point.
Okay.
First of all, giving realistic expectations. So Stephen is a good friend of mine, but when I went to see him, I was looking for, you're going to be better in 3 weeks, okay? Don't listen to all these people that say you're terrible. You're going to be better. That's what I was looking for from a friend. But Steven, smart enough to realize, you know what? If I tell him that and he's not better in 3 weeks, he's not going to not only trust me, he's going to make me lose hope. So you told me 6 months. It turned out that was like so important for me because I needed to say, okay, I have to wait 6 months. Like it really helped me in the long run. Sometimes you have to tough love. You have to be, I think that was very important for me to that regard. And then what was your next question?
No, so but bottom line is that you can tell just by over time that the 6 months was the goal itself. I was talking about the mirror. So
oh yeah.
yes.
So then I went to see. So I had a great physical therapist here in Miami, amazing, and she's still amazing. I see her for other things, but she basically gave up on me because it wasn't coming back. So she's like, okay, hasta la vista. But then I said, you know what? Wait a second. If I get a tendon transfer, which I was scheduled for a tendon transfer by this Dr. Alex Shin, who's amazing, in Mayo Clinic in Rochester, in Minnesota, and he was going to just move all the tendons and fix it. The same day that I was scheduled to have a meeting with them was the day that I saw a little tickle. I'm not joking. It was the same day I saw a little, but I went. Still, I wasn't sure if it was fully coming back because it was a little bit, and I went to see a physical therapist, an occupational therapist at UM. And the first thing she did was she took a mirror, which is so cool, and I took my right hand and she put a mirror over here by my left hand so you don't see my disabled left hand, and you look at your right hand and you look at the left and through the mirror and you pretend, you do the motions and your mindset.
That's right.
And I'm convinced.
Yes,
it was like a week
absolutely.
after that I really had something because you have to believe it.
You have to believe. That's why we're going to talk about
It was
the
mirror
podcast
therapy.
about belief therapy and belief, how strong beliefs are and confirmation. But yes, no question is that's got to your goal in mind, right? You got to have a goal. You have to have an intention, which is the direction of the goal. You need that GPS system.
Her name is Gayleen. She was great.
She's great. That's good.
Yeah, sorry.
And with the process of time and therapy, you got better. Correct?
Yeah, it's
full
incredible.
recovery?
I would say it's not full recovery. I would say about 80%. I'm so thrilled. It was sort of cool, the axonal regeneration. I remember I told you that. That was like, that's sort of cool from a neurologic point of view because the recovery you don't see. You don't see the recovery, but on the EMG nerve conduction, you predict it. So
Right.
you change your mind once you hear
Yeah.
that you have early axonal regeneration. I started thinking more positively.
Well, I could tell.
No, you don't see it.
Yeah, but I can tell when you came to see me, we did like numerous electromyography testing and we tested the needle and we were able to map out every single muscle
Right.
in chronological order of how it was going to heal. And once you got to that EIP, the extensor indicis proprius muscle, I knew you were fully going to heal
Right.
because every single muscle with 1 millimeter growth, right. Is going to go. And you mapped it out. I had really no doubt. And I knew that you're
The 1 millimeter a day.
Yes.
1 millimeter a day.
Yes.
How stressful is that? Thinking that it's going to grow, and then you have to wait 150 days to see if it really is growing. That's crazy.
That is crazy.
Yeah.
So one of the things I talk about is adapting to our new times. I have some difficulty adapting because COVID has changed our practice because there's telemedicine now. I choose not to do telemedicine because I like patient contact. There's now information overload. And I'm starting to see the new wave of doctors coming in. And I am so about the patient. We're both about patient first. We look, and when I approach a patient, I'm looking not only at that patient, I'm looking at the whole story, where they come from, what are their stressors, what are their habits. I mean, I get in so much detail, the things that I've never thought about. I'm seeing a new wave, and I'm not going to blame them because what's going on is that I'm not in that generation. And being in the generation of social media, which I'm getting into social media for the first time somewhat, and being into the generation of having the cell phone for studying, learning, and doing all these things, I'm having a little difficulty talking to some of the younger medical student residents because the analytical critical thinking has now started to, although it's somewhat advantageous because there's so many things you can get from it right away. So now I'm thinking, yes, it's great to know X and X, the side effects here. It's also great to get it. So I've noticed if I give a lecture, right, and now we're doing lectures and we're having groups of residents falling around, that cell phone is out and they're constantly on it. And I have 3 rules when residents and students, and it's like a child. Like I remember when I have a child in my house, and my wife used to put on there, wake up, brush your teeth, clean your bed. The simple rules. My simple rule is number 1, be on time. Number 2, no cell phones. And number 3, you're here to learn. I just want you to learn. That's it. Those are 3 simple rules. Okay. So now. I know you've noticed you're into this because you are adapting very well. You're like into the clinical medicine app and ChatGPT AI, and it's coming. There's no question it's coming. It's there. I use it for stroke. I'm using it in practice. What I am concerned about is the ability for doctors to start coming up on their own with a differential diagnosis and critical thinking. And I'm concerned about the compassion, because what's happening now, I know I'm talking.
No,
okay.
yeah.
What's happening now is go to any doctor's office, which we're involved with, go to the emergency room, and the doctor is spending more time typing on the computer and less in the patient's room. It's in there and out to get that note done, get those orders done, because we have to put all that information in. So we have evolved into removing ourselves out and into now AI, ChatGPT, order sets. They're just doing so many things that are progressing. What do you think, Ari, about this? What are you doing to adapt to it? I'm adapting.
So you're going to be surprised by my answer, because I
Okay.
have a completely different approach.
Okay.
Completely different approach. And the way my analogy is a stethoscope versus a CAT scan of the chest. So many years ago, we didn't have a CAT scan of the chest, right? So you would put a stethoscope in somebody's back and you would listen, decreased breath sounds, and then you would tap on the back and you'd be like, oh my God, there's no sound. This guy has a pneumonia. Oh, wow, Dr. Cement, you're amazing. But guess what? Nowadays, you have a CAT scan of the chest. You send them to a CAT scan, and there's no better picture than the CAT scan. You see the pneumonia. Why the hell do I need a stethoscope? The reality is that we have to adapt to the times. So this is my feeling. Now, I hear what you're saying. You're saying somebody's not going to be analytical. But I think, like my son, who's 14 years old, he is so quick on the computer because he's playing with it from the age of 8. So he's so quick and fast. These residents now, if they're savvy, like I've done with the AI, you could just be better and better and better with the tools that you have. And you could still have a different type of analytical thinking, but using the AI. Like I'm a big fan of, just today I had a weird case. I first plug it into AI, it shoots out a differential diagnosis, and then I'll see the next one. And if a resident's good, their analytical thinking is now going to be substituted. It's going to be different than you and I, but it's not going to be any worse. If anything, it could be better. It could build upon AI. I just have a different philosophy. Like some people are saying, oh, Dr. Cement, how does that here on the stethoscope? F the stethoscope. I have an ultrasound now. I have a CAT scan. You have to get with the times, and you have to advance with the new technology you have. That's my counterpoint.
Well, that's a counterpoint, and this is a good debate because, yes, I have all the tools. I do EMG in the office, nerve studies.
Yeah.
I order CT, PET, amyloid studies, MRIs.
Right.
I like the imaging. I like to correlate it all. But your dad is old school doctor.
Well, he knows
and
everything.
he is completely on the other side. There's no question.
Totally.
And the thing about your father, because he still practices, is probably one of the only doctors that tells me the diagnosis and what I need to order. And
Right. Well,
so,
I know. I'm
right.
just making I
But
hear
there's
you.
radiation exposure for CAT scans and
Right.
other things. And so I understand where you're at. And adapting is so important. It's just that the art of medicine.
It is definitely different. I'm not
Very.
saying it's worse, but it's definitely evolving, like amazingly.
It's interesting how you say
Positive.
amazingly and it's positive. I do think it's positive.
But it's going to
because-
replace everybody. It's going to replace us, but it's still amazing.
You really think so? The one thing that I am going to debate on that is that as a pulmonologist, it could be somewhat different because you're going to get a scan, you're going to look at the lung, and then you're going to have AI look at millions of lungs and pick up pathology that you can't see with the naked eye, and it's going to spit out something. I can see that. Now, the empathy, the connection.
Right.
Because
Of course.
I'll tell you
Yeah.
what my formula is for patients and how they get better is listening to them,
Yeah.
empathizing, connecting with them, mirroring them because they're subconscious. And then once they trust you, like that's the thing with you, Ari, is once they trust you,
Right.
any medication, whether it's placebo or a talk, is going to add the chances of you getting better
True.
by the treatment, because a lot of it's here, like you were discussing before about your hand. A lot of it is here. So they trust that you listen to them. They trust that you maybe order the test, and they trust that you are examining them, touching them, explaining to them the diagnosis. That's the other thing, is you want to listen, explain what they're feeling, and empathize. And then that's the formula. And then the tool is to add a medication or a therapy or whatever it is. So I just think that, Ari, is that I'm really into the patient experience, because that's the one thing, is that what's happening is I'm getting a call, and this is what I'm getting. You ready? Dr. Resnick, I have a 75-year-old man who has a history of weakness on the left side, consistent with likely a stroke. I'm admitting him for an MRI. So I stop right there, and I call the doctor, and I say, look, you're not admitting for an MRI. You're admitting to find out if the patient has a stroke,
Right.
make the diagnosis, prevent the stroke from happening, and getting his stroke back to the function where he was before, so he can recover and live back to where he
Right.
is less disabled and can function in life.
So,
See
yeah.
the difference
Yeah,
there?
for sure,
So
yeah.
that's what's starting to evolve here, and I'm like, oh.
More, yeah.
So it's the frustration, yet against strokes, with the strokes, the AI spits out the perfusion, the penumbra,
Amazing.
the TP. There's no question I use that.
I see the analytical.
The analytical mind. So I am very into the combination of two. I am adapting. And that's why I don't want to be that physician who is like, okay, sticking to their own rules and is going to handwrite their notes, not type their notes, not use the Dragon or the dictation services to help you, and so and so.
Yeah, I do think I was a better doctor before COVID. I think many doctors like me, sort of burnt out a little bit in terms of that patience. So I think that's...
So this is the thing. So you burnt out. So what I decided to do is that I decided to change my burnout by seeing less patients.
Yeah, that's smarter.
And spending more time.
Right, can't do that.
And I somewhat hang out with my patients now. And you kind of do
That's
that.
great. Concierge doctors do that all the time.
I know.
That's why everyone's going concierge.
Yes, and that's the thing, is it's medicine is that they realize that doctors are getting paid the same, but the expenses are going up and up and up and up, where we can't give the time.
Right.
So that's where we have to battle and all of those things. So
It's great.
all right, so Ari,
That's fun.
thank you so much. This was a great conversation to talk to somebody, and actually we're like catching up, to someone who I've known my whole entire life, and who, from playing sports to hanging out in school to being in your house, sleeping over,
I was in
getting
your
to
house
know your
much more than you're
family.
in my house.
I'm getting calls that Ari spends more time with my mom than I do. That's
I know, I
fine.
love that.
Which is a pleasure, because my family adores you
I
and
love
loves
your
you.
parents. I love your parents.
But getting into the mindset and the compassion and being a hero, Ari, I'm calling you a hero because you stepped up and you really brought it up, and you were recognized by the city of Miami Beach. You received a key to the city. Is that correct?
Yeah, a few keys.
I'm not sure what it opens to, but maybe a safe. I don't know. So, and you made a lot of connections through COVID. You
Right.
learned from COVID. So you grew from COVID. You just changed your practice through COVID, and you evolved. So that's an evolving, or what we call growth mindset. But Ari, as a person and as a human, I mean, you're a true mensch.
Love you.
I love you, brother.
Love
know
you
that.
too.
All right.
It's
Thank you
awesome.
so much.